Good afternoon, everyone, and thank you for returning to this session to talk about stigma in the carceral system. We're truly excited to have you here for this really important conversation, and one that we're all very passionate about. I'm really excited to introduce our panel today, but as a reminder before I do that, we do welcome your questions for an audience Q&A, which will close out the session, and you can submit those questions in the submission box below the feed. We are getting a lot of excellent questions that we can't get to, so please keep them coming and we'll do our best. With that though, I would like to introduce our panelists this afternoon. So Morgan Godvin is a formerly incarcerated person in long-term recovery. She's the founder of Beats Overdose, a harm reduction provider for the music and entertainment industry. She serves on Oregon's Drug Decriminalization Measure 110 Oversight and Accountability Council, Oregon's Alcohol and Drug Policy Commission, and Portland's Multnomah County Public Safety Coordinating Council. She's a narrative justice fellow with Health Injustice Lab, whose work focuses on drug-induced homicide laws, overdose, and incarceration. She's the engagement editor at JSTOR Daily, assigned to the American Prison Newspapers collection. A 2022 Bard Prison Initiative Public Health Fellow, she is studying medications for opioid use disorder in carceral facilities. I am also thrilled to introduce Brandon Del Pozo, who served 19 years in the NYPD and 4 as the chief of police in Burlington, Vermont. While at the NYPD, he commanded the 6th and 50th precincts, as well as units in internal affairs, project management, and strategic initiatives, and served on the staff of the police commissioner and chief of department. From 2005 to 2007, he was deployed as the NYPD's intelligence liaison to the Arab Middle East and India, based out of Amman. In Burlington, his work included leading the city's response to the opioid overdose crisis and helping develop and drive national innovations in the use of force. His present research interests include systems-level responses to the nation's overdose crisis, especially through the use of agonist medications, and the intersection between policing and public health. Lastly, it is my pleasure to introduce the moderator of today's session, who in her own right is an exceptional researcher, Shannon Gwin-Mitchell, who is a senior research scientist at Friends Research Institute in Baltimore, Maryland. A community psychologist by training, she has been conducting qualitative and mixed methods research around the intersecting topics of substance use, drug treatment entry, and crime/criminal justice for the past 20 years. Her work focuses not just on individuals, but the systems in which they work and live, and how those systems impact individual and organizational functioning. She has served as PI or COI in nearly 20 studies funded through the National Institutes of Health, and has authored or co-authored over 100 peer-reviewed publications. With that, Shannon, I'm thrilled to turn it over to you to kick off our conversation today on addiction, stigma, and the carceral system.
Thank you so much. I wasn't sure I was going to be moderating this. We don't have any questions yet, but I know when Brandon, Morgan, and I met, gosh, it was a few weeks ago, to kind of hash out the direction of this particular session. It went in some really interesting directions. And I know that the emphasis so far has been on experiences of people in the systems, going through these systems. And I wanted to maybe start by opening up to Morgan and seeing if she would like to reflect upon the issues surrounding the justice system and the stigma associated with addiction and the way that it sort of led to the trajectory of her current work.
Yeah, hi, thank you. So I typically like to frame these discussions as what is stigma? When we say the word stigma, and we very often are talking about some sort of vague or nebulous interpersonal interaction or relationship, stigma. I mean stigma as the direct result of our laws and policies. In 2013, I was arrested for felony drug possession here in Portland, Oregon, and mandated to court treatment and this and that. And when I'd had a relapse, I volunteered to go to jail for the very first time in my life, because I'd only ever been released on my own recognizance, because I wanted to be restabilized on my buprenorphine. And so I got a letter from my doctor. I brought in the medication, the prescription. I stepped up to the podium and asked the judge to take me into custody. It was one of the dumbest things I have ever done, because by that night, I was in acute withdrawal, and the medical staff at the jail was telling me it is against their policy to prescribe medication for opioid use disorder. I kicked cold turkey in an open dormitory while 77 other women looked on while I vomited into a trash can with fluorescent lights that never turned off. It was one of the most traumatizing experiences of my life. I never took Suboxone again. I got out and I returned to heroin and was sentenced to federal prison about 9 months later. It dramatically accelerated my trajectory into incarceration. It worsened my addiction and my criminality. And the fact that I never took the Suboxone again, that's actually reflected now in evidence-based research. When people are traumatically interrupted from their medication in carceral facilities, they become much less likely to resume treatment upon release. So what happened to me is not unique. And what happened to me is continuing to happen to hundreds of thousands of people. So when I say stigma, I want to talk about our laws and I want to talk about our policies that are producing the stigma. The stigma is the result. It is not nebulous. We can fix it if we fix the laws and policies.
Thank you so much. Brandon, did you want to reflect on your perspectives as well?
No, I think what Morgan says as a person with lived experience is so powerful and hard to deny. And, you know, as not only a former chief of police and not only as someone working in substance use, but someone who's actually PhD training is in political philosophy, you know, we can't forget how stigma and norms go together. And what Morgan describes is not only just the jarring experience of going into forced withdrawal as the quote unquote right thing to do, quote unquote, but people, regardless, I mean, that there's a legitimacy crisis in wide swaths of our communities with regards to policing. But that said, policing still has the power to set norms. And by number one, like criminalizing the behaviors that associate with addiction. Number two, like criminally punishing those behaviors. And then number three, countenancing things like quote unquote sobriety or detox over medication assisted treatment. It's this cascade of stigma where the public looks at what the government's doing, looks at what public safety is doing, looks at what leaders are doing, says they care about us, they have a mandate to protect our health and our safety, they must be doing the right things. And then you have folks in Morgan's position getting caught, like you can call it a cascade or a vicious cycle, but it entrenches the stigma, right? And I think that's you know, that's where we're going. I mean, one thing I'll say, I'm teaching a comparative drug policy course at Georgetown. It's a Master of Science in Addiction Policy and Practice. Wonderful students. We're looking at international drug policy, and it's remarkable. Now that the Taliban has taken over Afghanistan again and rules the roost, they have gone on a poppy eradication policy that tracks U.S. policies about eradicating the crops that are used to, you know, make drugs. They have also, when they appeal to their response to addiction, they say that sobriety is what matters, that what God would want literally is people to be off these drugs. And their mechanism of addressing the individual level addiction is detox, is forced detox, right? And the students and I, as I'm preparing this lesson and delivering it, had a light bulb moment go off that there are differences in magnitude. I am not equating the Taliban to the American government, but certainly the forced detox approach that they are literally taking tracks the U.S. forced detox approach in a carceral setting.
Yeah, that took it out to a whole other level. I wonder, Morgan, something that you said really resonated with me, and that was how the way you were treated during your incarceration negatively impacted the trajectory both of what happened when you got out, but your recovery in general, and having, you know, interviewed participants in other research studies that we've done about their drug treatment or detox experiences in jail and how it impacted their willingness to seek care in the community, particularly unlike a long-acting medication like methadone, where the detoxification process, if you're improperly medicated, is really prolonged. It's a really, really miserable, protracted process. And it made them worry about, it's not if, it's when I get incarcerated again, I don't want to go through that. And it really became a barrier for their willingness to re-engage in care when they entered the community. It sounds like it was similar with you, and it was buprenorphine, correct?
Absolutely. And it actually even predates the medication experience. My first engagement with treatment, I was 21 years old and I was sent to inpatient rehab. 12-step is the only way. That's how it was projected to me. And I grew up in a military family, and I was there on military insurance, and the federal government was paying however much to send me there. And all it was a series of 12-step meetings from morning to night in these group therapy sessions. And I remember trying to talk to my counselor saying, I don't really, this doesn't resonate with me. This isn't working well for me. Try harder. Maybe you don't really want recovery. And so then you start to subtly intake these messages. And then you see 12-step working for other people. It does work for some people. I had friends that was their pathway, but it was not mine. And yet I was never once presented with an alternative. And so I started to grow this resistance to treatment because I felt hopeless. I felt beyond help. And so that progressed, but the absolute cincher of my reluctance or my hesitation to engage with treatment was that buprenorphine experience. And I just want to give this a little more context, just how devastating it was for me emotionally. I am a military veteran raised in a military family. And because I am white and middle class, I was able to go forth in my life with some vague notion that, yes, there's some bad stuff that happens, but America is basically fair and just. Okay. And that notion, already founded in racial and class privilege, was just shattered that day that they refused me my buprenorphine, because it was so obvious, so salient, that they were punishing me for the sake of punishment. Nothing inherent in that system was to make me better. Jail makes people better. That's why we send there, right? But it was strictly punitive. And so I felt betrayed by my entire country, by the policy. It soured me to absolutely everything. And then it has left me to this day with a sort of traumatic stress response around medications that require daily dosing. So during COVID, when my mental health tanked and I came very near to relapse, my psychiatrist was begging me to try SSRIs. And I said, no, I won't do it. What if I go to jail? It doesn't matter how irrational that is, how I'm not committing crime. What if I go to jail and then, I go through the serotonin withdrawals in jail? And my psychiatrist is just trying to talk this stuff out with me. And this is almost a decade ago. And it's still, I feel it so acutely, so viscerally. And I've had friends who were forced detoxed off of methadone in Skagit County Jail in Washington. And he got out and died of a heroin overdose. So your policies are killing us. That's all.
Well, I know that you both alluded to this sort of meta message that the system gives when you come in and you have an addiction by virtue of denying basic health care. Even for someone who is on a medication, established on a medication, has brought that medication into the facility and being denied access to that. Those are there's this meta message about, you are here and we're going to punish you for your addiction. I wonder if either of you can speak to more direct, overt instances where the justice system and people involved in the justice system are stigmatized because of that addiction in a really direct way. The withholding medication is one thing. Another thing is to say it's time to get through it and be punished or whatever. And I just don't. I wondered if you could speak to that.
Hey, Morgan, may I say one or two things? Do you mind?
Absolutely, Bryn.
Yeah, thanks. No, I think that, the experience Morgan talks about when we look at a response to it, and then I'd be happy to shift over to that question, Shannon, is, so Americans with disabilities have frequently been stigmatized, and what we rely on in many cases is the ADA to undo a lot of that stigma, or if not undo it, to at least protect people from the effects of the stigma. And one of the ways forward we're seeing, and it's incremental and it's winding its way through circuit courts, is rulings that people suffering from addiction in a carceral setting are people with disabilities, and that not providing them with the medication that keeps them safe and helps to improve their health is a violation of the Americans with Disabilities Act. So you're seeing in a few jurisdictions the courts making those rulings. There's a notable ruling in a New York County that said that everybody who demonstrates a need in the county jail for medications for opioid use disorder as a matter of their rights needs to get treated. So hopefully in the long run, we'll see some legal protections that might do, if not reduce the stigma, at least ameliorate it. But one of the things I think that we overlook, more to answer your question, is this problem with criminal behavior and stigma, meaning not just criminal behavior as drug possession or syringe possession, but people breaking into cars, people stealing things in order to commit subsistence crimes to fuel addiction, right? To provide themselves with the money for the drugs. Like that has this double problem of all right, not only are you a quote unquote drug user, quote unquote addict, quote unquote junkie, but you're a criminal too, right? And so again, that's that cascade. And where I see it coming to roost in policing is officers have, and it's one of my main research interests, is officers have a tremendous amount of discretion as to how they respond to situations. If it's a misdemeanor, if it's a nonviolent misdemeanor, officers have near complete discretion, right? And so in some cases, they're being offered the opportunity to deflect people directly into treatment. In other cases, they're offered the opportunity to give a warning rather than send someone to jail, right, and have them suffer from detox. And the number one indication in my research of what influences their decision is the quote unquote attitude of the person they're dealing with. And cops, it's a very human thing to say, if I have the power to make a decision, your attitude is going to influence my decision. Attitude is never more than a hair's width removed from stigma in the realm of people who use drugs, right? I'm being lied to, they'll say. This person's nervous around me. They'll say anything to get away from me. They don't really mean that they want treatment. They just want to get out of here. Those are all things that cops report people who use drugs as conveying to them. But so many of those things are based on stigma. So I know I've gone on at length, but I'll say that one of the ways in which it manifests in criminal justice is when police need to make these life-changing decisions. They have the authority to make these decisions, and they make the decisions based on stigma. Thanks, Morgan, for giving me the floor for a few minutes. Yeah.
I just want to piggyback off what he said a little bit.
Please.
The word criminal specifically, felony, crime of great moral turpitude, you'll see in some other legal doctrine, right? The word criminal doesn't mean anything when it means everything. And we have just stretched and contorted that, and it just casts such a wide net. I mean, I was called a criminal and given a felony conviction while still in my work uniform, while a full-time student and a full-time employee, because my drug of choice was heroin and not alcohol, okay? And so you were criminalizing not what would have been considered a crime 100 years ago. Like I wasn't committing crime, breaking into things. That's one of the things that always frustrates me is like the war on drugs dramatically expanded who we were considering a criminal. And then relatedly, criminals, quote unquote, are the only demographic in the United States where you can get the American public to say, yeah, make them hurt, make them suffer. We have conditions in our prisons that we wouldn't allow at the dog pound. And like, that is a fact. Texas prisons are not air conditioned. That would not be allowed at the Humane Society, but it's allowed for human beings as long as you first affix the word criminal to them. And so trying to break the link between drug use and criminal in the American populace will go a long way to implementing more evidence-based interventions, more compassionate responses, because right now we have linked drug use and criminality inextricably, and that is affecting everything from officer perception to our body of laws and policies. Those things must be extricated, or we will never make progress.
Yeah, thank you for adding that. It's so important. That one of the things that you're hitting upon obviously is the intersectionality of this stigma as well, and the idea that, you know, you mentioned white privilege early on, you know, as like, this was just foreign to me that this would happen, but most of the people who are involved in our carceral system in the United States are people of color. And so there is the addiction, there is, when they get out into the community, the criminal justice stigma associated with having, you know, served time, and the institutionalization of a lot of the barriers that are created because of that, whether it's felony or not. There's the issue potentially of stigma associated with whether or not you go through recovery and you're using medication as part of that. I think you mentioned that as well, that the medicines that we use to treat substance use disorders, like opioid use disorders, themselves carry stigma. So there's just a lot of layers involved with what we're talking about here. It doesn't end when you leave jail or you leave prison or you're on probation ends or whatever. It follows you into the community. And in various ways, those messages, as were alluded to in one of the earlier presentations that we had today, can become internalized. You start to believe that message about yourself. And I wonder if you all would like to speak to that issue as well, how hard it can be to filter out. Like, we can change systems, it's going to take a long time. There are lots of things that have to happen at multiple levels, thinking in term of an ecological perspective. But at the heart of it all, you need to create resiliency, that emotional armor to protect yourself from believing those messages about yourself. I think a lot of the things that we heard early on in some of the presentations today, particularly the sessions, was how hard it is to try and view yourself as a human when you keep getting these meta messages that you're not, because you're not treated like a human being. I wonder if you guys could.
Yeah, no, that's such an insightful. So first of all, when you talk about the interface or the intersectionality, it's not just criminalization and substance use. It's also homelessness. It's also mental health, right? When you look at stigma, you know, the stigma and mental health are, you know, travel hand in hand. And substance use is one of the few things that, like, closely, like in terms of magnitude, tracks. Like, substance use and mental health are both highly stigmatized, more so than most other conditions. But throw in homelessness, throw in poverty, again, mental illness, criminalization. It's just like all of these things are associated with untreated addiction, and they just compound each other and make it worse. But as far as that internal stigma, I think and we talked about race for a bit, and we need to take that head on. You know, one of the things we promised ourselves in the heroin crisis and the opioid crisis is to not make the war on drugs mistakes. And some people noted, well, we've done a great job of bending over backwards for that when the predominant victims were white victims versus victims of color. But if you look at it, right, during the beginning of the opioid epidemic, people were served a narrative that helped them resist stigma and that helped them, you know, explain what happened, which was, it's not, you know, it's pills. You were probably a soccer captain or a stressed out mom or an athlete or a student working hard or someone in a car accident, XYZ. And then doctors and big pharma came and gave you pills. And despite your best efforts, like, because of this medical condition, this injury, you became addicted. It's not your fault, right? Now, someone could say that a lot of what made taking those pills so appealing wasn't the back pain or the conditions from the surgery. It was the same, like, self-medication that goes on when someone uses any type of opioids, including injection administered opioids. But here's the point, like, in this new wave of the overdose crisis, people were hand delivered a narrative that like explained away and obviated a lot of the stigma of their addiction, right? When you look at Black communities who didn't have as much access to opioid analgesics, and you look at like how it was entrenched in their communities, it was always an injection. In Washington, D.C., for example, it's a very long-standing community of injection users. Nobody was bending over backwards to give injection users like an origin story, or don't worry, it's not about you, it's about big pharma. Don't worry, it's not about you, it's about doctors, right? So we created this narrative that insulated, in the beginning anyway, opioid analgesic users, which were predominantly white, from the stigma. We never afforded Black communities and brown communities that luxury, and now we're dealing with it.
Yeah, and just, on that, white people are far more likely to be on buprenorphine, which is prescribed in like a PCP setting, a clinic setting, regular doctor visit. Meanwhile, Black Americans are far more likely to be on methadone. Everyone has lower access, or our uptake of medications for opioid disorder is not where it should be for any demographic, right? We understand that. But there is a racialization difference. And then for the first time in my life, I was at a methadone clinic this morning. I was there as a patient advocate for my friend. I felt like I was at the probation office. People walked in, put their number, reducing human beings to a number, into a machine, and then it popped up on the screen whether or not they had to go take a UA. Then they would get their little UA cup and walk into the bathroom that had 360-degree cameras and pee into the cup on camera. And just having, everything scrutinized, and we're waiting in line and it takes hours, and the clinics, you have to ride the bus. It literally felt like a jail. I felt like I was in the waiting room of the probation office. And it was just so immediate to me how, of course, those systems, systems of authority just start to blend together. When you're a person who uses drugs, you are being stigmatized from the justice system, from the medical authority, which has interplay with the justice system. The people ahead of me on the clipboard when I signed in at the methadone clinic were with the DEA. They had their inspection yesterday, clearly. And so these things just become just sort of one overarching system of authority. Anyone who's handing me a cup and saying pee in it, you are the cops. And so we have created these punitive systems, calling them treatment, but they feel punitive like jail. Jail is definitely punitive, no treatment there. And then we wonder why we have poor uptake of medications for opioid use disorder. It was very heartbreaking for me at the clinic this morning. I can't believe we treat people like that. Of course, like as long as you're going to put so many barriers and make it feel so punitive to engage in treatment in that way, people were not going to choose that. You're making it so much harder to engage in treatment than it is to buy drugs. Come on.
No, Morgan, that's such a good point. I mean, I was on the board of the biggest addiction service provider in Vermont, so I got to see methadone clinics just as part of being on the board. And they reminded me, they were like a quasi-carceral environment, right? Things were locked down, you were constantly under surveillance. You had to they had mirrors everywhere in front of the booths where you took the methadone to see that you weren't secreting anything. And then the unlawful possession of the methadone, so to speak, is a crime, right? It's regulated by the DEA, and if you're found without, and same thing with buprenorphine, right? If you're found without a prescription, it's a crime. So again, it's that carceral mentality. Even the most effective medications for keeping people alive are presented and framed and distributed in a way that is quasi-carceral or could become carceral if you don't have a prescription.
Yeah, OTPs are a whole other world, aren't they? Absolutely. One of the things that that is happening state by state, but looks like there's some movement, is legislation mandating that people who are in jails, come through jails, be provided medications for opioid use disorder rather than being forced to detox with some minimal medication. Those are ramping up. And so there's a cart and a horse issue that I think a lot of us that are looking at implementation issues in carceral settings are faced with is, does the system need to embrace this as valid and decrease the stigma associated with it in order to effectively provide these medications? or does providing these medications and these systems change the systems themselves in a way that will eventually reduce the stigma? So if you provide it whether you want it or not, and you see people are doing better, maybe the milieu improves because, like you were talking about, that horrible withdrawal experience, Morgan, around 70 other people with lights on all the time and being physically ill for days at a time. If the intensity decreases and potentially those who need the medication are being provided it, does it decrease contraband that's coming into the facility? Because we know that there are, people don't just go without. Usually there are ways to treat and get what you need, but it creates additional problems. So the idea of you medicate people appropriately, does the system itself improve? And then of course there's stabilizing someone and how do you transition to them in the community? So I don't know if you guys had thoughts on what actually providing these medications would have done for people in terms of decreasing the stigma that they experience. How different would that be? And then of course there's the transition to the community and what having access to appropriate treatment during a detention would mean for successful reentry into the community.
You want to take it, Brenda? You're on mute.
I'd love to hear your perspective on that as somebody who's lived through so much of this, but I think that, I mean, part of it, part of this, what will help some of this is aligning public health and public safety and aligning rehabilitation with and treatment with public safety, right? Is that right now, you know, it's a completely disparate mindset. Like some places are great, like Rhode Island has comprehensive medication for opioid use disorder in all its jails and prison settings, right? As does Vermont. They're small states, geographically small, they could scale it up pretty easily. But what I remind police officers is that if your job is to reduce crime, if your job is to reduce robbery and theft and you know, the effects of substance use, the medications are by far the most appropriate and effective way to do that, right? It's not some misdemeanor court system revolving door. So I think at least as far as the first responders are concerned, I guess what I'm giving you an answer to is from a cop's perspective. If you want to destigmatize medications for opioid use disorder and you want to destigmatize or lessen stigma against people who use drugs, explaining to officers that this is an effective public safety intervention, as much as it is a life-saving intervention for people with addiction, I think you're making a little bit of headway. Like I'm not going to say the kumbaya, but if the cop can deflect someone to treatment and then say at the end of the day, that deflection increases public safety, I think it helps. And it's not a false narrative or a shell game. It genuinely does achieve both ends, like robustly.
Yeah, wholeheartedly agree with Brandon there. There has been really poor messaging. Again, this is entrenched in policies because for so long drug courts held abstinence up without, you know, and restricted the use of medications for opioid use disorder. And so other people in the criminal justice field started to internalize that and reflect that out in their values and actions, including police officers. And so there's this stigma around medications for opioid use disorder, but as Brandon just said, they make us safer. They reduce recidivism for people who have committed crimes. And so if the police and the court system's job is to make us safer, therefore their job should also be to get as many people on MOUD as possible. And that definitely means providing it in carceral settings.
I think also in judicial settings, it's important. No, thank you, Morgan. It made me realize something. That we need to give control of the treatment plan over to the qualified professional and not the judge. Like the judge is the judge. The judge runs the courtroom, right? But a judge with some humility would say, justice is my goal, but this is addiction that's driving the reason why this defendant, so this client is in front of me. Like, I'm not going to pretend to know what the best course of treatment is. Like judge is saying, the person in the courtroom that's going to really set the trajectory here is the treatment provider, I think goes a long way towards reducing stigma in these settings. It's acknowledging that it's a medical condition. It's acknowledging the disease aspect of all of this. It's saying treatment is effective enough that the judge is willing to place the decisions in the provider's hands instead of judges just kind of winging it, which is what a lot of problem solving courts do now, is the judge just kind of wings it. And I will say, judges in a lot of settings have gotten a lot of free training from Alkermes about Vivitrol, right? Which is like the least effective of the three medicines. So in research that my colleague in University of Central Florida is doing, Basha and Draka Christou, judges trust Vivitrol and trust Vivitrol-based treatment more than they trust methadone and buprenorphine-based treatment, right? And that just kind of compounds stigma, because if you're in the audience and you know or you don't, like Vivitrol is basically like sticking a chastity belt on a human being and saying no opioid will touch any of your receptors. You will not get any pleasure out of any medication, no matter what. It's like, we could talk, it takes a whole other class to talk about that, a whole other session. But anyway, I'm saying all of this makes the case for turning the decisions in court settings over to the medical folks rather than the judge when it comes to figuring out what to do with the client.
Who that treatment provider is, though, what treatment perspective they have is really a really important thing to keep in mind. Doing implementation research in carceral settings surrounding MOUDs, sometimes the biggest barrier is the medical staff in the health suite. It's not necessarily the warden or the custody staff. It's the health staff. It's whoever the provider is, a lot of contract providers, and getting them to embrace that this is an important healthcare service to provide, and making sure that the people who are providing it are comfortable and not additionally stigmatizing the people that they're supposed to be helping. There was a whole other session that just went on before lunch about stigma in the healthcare system. And those in health suites in jails and prisons are these little micro communities. Actually, sometimes they're major healthcare providers because of the number of people they serve coming through those facilities as well. You mentioned, Brandon, several times about the importance of knowledge, like educating people. And when we look at decreasing stigma and increasing access in like research, we usually include some sort of like knowledge, attitudes, and perceptions measure to try and understand how much do they know. If you give them more information about addiction in general or medications in general, will the stigma decrease and their acceptance of it increase? I think we've been treading into the more you know, the less you fear. And sometimes the responses and the stigma it's about ignorance and it's about fear. A lot of addiction also has other behavioral health components too. Very few people, particularly people who end up involved in the carceral system, don't have other sorts of trauma or serious mental health, behavioral health issues that also are going untreated. And I wonder if you all can speak to training with trauma-informed care, in addition to it, like being incarcerated in and of itself is a traumatic experience. And so you have maybe pre-existing trauma, and as well as often very serious mental illness, and then you're trying to deal with an addiction and everything else in this very artificial, very constrained system. And I wonder if you all can speak to the necessity to integrate other behavioral health or specifically trauma-informed care.
Yeah, I'm going to jump on that one a little bit. So I experienced a wide range of types of medical services provided by different facilities. So in Multnomah County, it was the county health department. So it was actually decent. Okay, you could get cavities filled. There was a dentist. You could see a mental health counselor, master's level, every 6 weeks, which like is not sufficient for people with high levels of trauma and addiction, but is the best that I saw out of any of the facilities. I saw various types of private medical, Corizon, Other ones, because I did my time split between a bunch of different facilities. I saw the United States Public Health Service provides most of the medical care in federal prison. This is what I wanted to get to. I do not understand which policies, procedures, prevailing beliefs, or workplace culture produced it, but I have never seen such atrocious treatment of human beings by medical providers. But the way the Bureau of Prisons does it sets themselves up for failure. And this is something I want to talk about because not all jails and prisons do this, and it is correlated with outcomes. Are you a medical provider first and an employee of the prison second? Or are you first and foremost a correctional officer, then medical provider? So when I was at FCI Dublin outside of Oakland, California, there was one psychiatrist for the prison, for the entire prison of 1,500 highly traumatized women. But they have staffing crises that have worsened since 2017 exponentially. But even back then in 2017, it was during the Trump hiring freeze, so they had staffing crises. So what would the psychiatrist be doing? He had to play correctional officer. So he would get keys and a walkie-talkie and walk out, and he would be patting people down outside of food service, making sure you weren't sneaking bananas in your bra. That poisons the mind of providers. There must be a bright line distinction between you as a medical provider under the Hippocratic Oath and you as a correctional officer, because that is not doing harm. You cannot play both roles. You cannot pivot. The human mind is not capable. And you would see it, especially in federal prison, where they were often tasked with working as correctional officers. It eroded the quality of their treatment. They stigmatized you. We were all widely considered to be lying about any medical complaint that we had. People died of intestinal cancer because they were just kept told to drink more water. And then, so that's the setting in which we're talking about then somehow providing high quality evidence-based treatment for addiction. And so there's definitely a disconnect here that will need to be resolved. Some very clear implementation, very clear standards, and a dividing of correctional duties with medical duties, because you cannot get trauma-informed care by the same person that is traumatizing you.
That was very powerful. One of the things I wanted to say before I answered Shannon's questions is we're giving Shannon short shrift here because she's like the super accomplished researcher that actually, she may not have been a chief of police or lived through addiction, but knows the answers to all these questions and probably has a better grasp of the research. But she's like very graciously eliciting from us that knowledge as participants. So it just occurred to me, yeah, she knows all this already. So anyway, so thanks for asking these probing questions. So first, I think it's not just what you know, and the more you know, the better. Research shows it's simple, didactic training doesn't necessarily reduce stigma, or the effects aren't big and long lasting. But I think what does work is taking that knowledge and situating it within the actor's worldview. So giving police officers the knowledge to figure out how addiction and treatment and all of that fits into public safety and officer safety, officer wellness, their role and missions as a cop, that helps more than just presenting them kind of neutral knowledge. One of the things that Morgan and I work with Leo Beletsky, who started SHIELD at Northeastern University. SHIELD is for first responders, and it takes all the principles of harm reduction, all the principles of MOUD, and situates them within a police officer's worldview. So it's not just the agnostic presentation of clinical knowledge. It's we acknowledge your role as a cop. We acknowledge your need to stay safe as a cop. We acknowledge your need to protect the community, to save lives. Here's how it all fits into that. So it's instrumental knowledge, and that has more of an effect on reducing stigma than just simply straight up knowledge. And about trauma-informed care, one of the things I'd say, and we don't have time to go too deeply into it, is that police need to have a trauma-informed mindset when they're gauging the attitude of the person in front of them. When the person is nervous and shaking and looking away and just wants to get the heck out of there, and is maybe just bald-facedly lying to the cop. That's not out of haha, I wake up in the morning and I just want to lie to police. That is coming from a reservoir of trauma, right? if this cop arrests me, I am going to go into terrible withdrawal. If this cop arrests me, I'm going to lose my job. Like, I am scared of what's about to happen. So it's not, just trauma-informed interventions. But when that cop is interviewing the suspect who just broke into the car and they are behaving in a way that's like really disingenuous, that is coming from trauma. Cops need to understand that.
I want to just really quick. We have created in law enforcement in the exact setting that he described, in family, in relationships, with your doctor. I just want you to think, are you creating an environment where people can tell you the truth? Or is telling the truth for them an irrational choice, right? Rational choice theory. Most people are being rational most of the time. And if they're lying to you, that is because you have created a scenario where telling the truth is going to be more harmful to them than lying. And so they choose lying. And I felt that so many times. Like, nothing about being addicted to heroin inherently made me a liar, or, didn't turn me out to be a criminal. But I could no longer tell the truth. Do you think that I could show up for my EMT training and be like, hey, yeah, I'm addicted to heroin? No, I would have been kicked out. Could I tell my boss I was addicted to heroin? No, I would have been fired. And then again, like police officers, are there any drugs in the car? That is a setup. The answer is no, And so we have just created a landscape for people who use drugs that pushes them into the shadows and forces them to lie and conceal parts of themselves. And that really inhibits these people finding recovery, because the further and further you push them into the shadows, the harder it is to get back.
Yeah, thank you. Thank you. The pressure that the system has in shaping our behavior just cannot be overlooked. And sometimes it's not as direct as it is when we're talking about these power differentials and the incentives versus disincentives for what you're doing and what it's going to lead to. It really exacerbates everything. I did want it, we have a little over 10 minutes left. And I wanted to take the discussion a little more out into the community, because the criminal justice system obviously isn't just prisons or jails. There are a range. There's diversion courts, problem solving courts, there's probation and parole. And the potential stigma that addiction carries for people even out in the community, if it's with their PO or if it's with the judge in the problem solving court, is really significant as well. And it cannot be overshadowed. Brandon, I think you alluded to it when you were talking about problem solving courts and the judges making treatment decisions, which is obviously, it's good to feel like you know everything, but it's good to know where your limits are and where your expertise ends. And I wondered, I know from some of the previous studies that I've done, if you are released into the community and you are on parole, and one of the conditions of parole is, of course, that you not use substances, or that you go to your treatment program, your PO will be calling the treatment program or doing your drug testing to make sure you're complying with it. So of course, if you have used, rather than pee in the cup and be, recidivated, you just don't show up, which is a whole other violation of your probation, right? If you go to the treatment program and they drug test you and your PO calls, again, getting your methadone is contingent upon the results of your analysis. So that therapeutic line that I think was brought up, the idea that how can you trust the person that you're supposed to be forming this therapeutic alliance with if they are also basically making the rules and enforcing the rules. We did a whole study on methadone treatment that was about re-engineering methadone treatment and trying to separate and have the therapist be therapists and have those who are enforcing the rules be the enforcers, because they get blended. It's staffing issues like you talked about, prisons being understaffed. Methadone community treatment programs are often under the same thing, where you have to serve multiple roles because it clouds your ability to be effective in what you're actually trying to do, your primary focus for being there. And I don't know if you guys had experiences that you would like to talk about in terms of either probation or parole and the stigma of addiction and the barriers or facilitators associated with POs in that process, or with problem-solving courts in some way.
Yeah, I can just really like personal story, Brandon, and then you come in with your systemic analysis. Okay, we're gonna tag team it. After that buprenorphine horror story, and I was raided by the SWAT team, and I knew that I was in trouble, and I never committed another crime after that day. I was not arrested that night, and I dedicated myself to finding recovery. So the next week I went down to Portland State University. I got a traffic ticket for not feeding the meter. It's here on this paper for my expungement. I can like see the day that I went to Portland State University to try to enroll. And then I went to the methadone clinic. Buprenorphine, obviously, I had flunked out of with some help from the county jail. And I had multiple failed treatment attempts. And so I was like, okay, I'll do methadone. Maybe that'll work for me. But I was on probation for felony drug possession, which is infantilizing. And it should, like, you're a criminal, your decisions must be monitored, you're not to be trusted, and you can't just engage in highly effective evidence-based medicine. You need to get written permission from your probation officer. So I had to try to get written permission from my probation officer the week after I was raided by SWAT and was may or may not facing a pending indictment. And then the methadone clinic also requested my failed treatment attempts, that I get them those faxed. I was in such bitter, active addiction, in hell and homeless. Even the most minor of barriers can become insurmountable in that situation. And again, it's exactly what you said, like, who are we letting dictate the treatment decisions? And how does my probation officer have any authority to tell me that I cannot be on medicine? But that's the way it is. I think it's gotten better here now in the Portland area, at least. I don't think you need written permission anymore, but there's still stigma around it. There's still this messaging. And so no wonder methadone is stigmatized. It feels like a jail when you're at the clinic. You have to deal with your PO. You're being positive for an opioid. It's there's just so many overlapping layers here. And then the same with treatment courts. You know, I was in drug court. The judge would like ask people at the podium what their methadone dose was. Like, isn't that wild? How can a judge in a public record courtroom, well, what dose are you at? Anyway, so yes, take it away, Brandon.
As an aside, one of the toughest physical fights I ever had as a police officer was with someone with opioid use disorder. And at the time, it was over a decade ago, I knew nothing about the physiology. And there was a good reason to take that person to jail, and they needed to be arrested. And my partner and I were like, why are we fighting this guy? Why is this guy fighting us physically? I'm not talking about on principle, like fighting us so hard. I've arrested like literally attempted murderers more easily. And now looking back, I'm like, that man knew that he was going to go into withdrawal, knew he was going to suffer, was scared out of his mind, and just was in a very personal, emotional, almost animalistic way, just trying to protect himself. And granted, like, I don't think that would have changed us subduing him, but I have so much more sympathy towards. Instead of me at the time, I was like, this must be motivated by malice. This must be a terrible person. What the hell? This person's putting me in danger. Now I realize like what we were setting him up for and why he was resisting. But getting back to probation and parole, like one of the things that stigma causes, and this goes back to my training, my doctoral training in philosophy, epistemology is the study of knowledge. And one of the things that stigma does is it causes what philosophers would call epistemic injustice, which is where we don't take the knowledge of people we stigmatize seriously, right? When it comes to people who use drugs, people in positions of authority don't take their testimony seriously, don't take their knowledge seriously. So you have Morgan like testifying, so to speak. I know what's going to work for me. I know what I need. I know where my life is. And sometimes, listen, it's not always entirely accurate, right? But people make these good faith statements often. This is where my treatment needs to go. This is how I'm going to keep a roof over my head. This is how I need to be employed. Maybe I do use cannabis, right? But Methadone will keep me at my job, even if I'm using cannabis. And what we see authority figures do is just completely reject that knowledge. Nope, there's rules. The rules are made by clinicians and scientists. They correspond with laws. No matter what you're testifying about, what's going to get you to a better place, we're rejecting your testimony and we're going with what the rules say, right? And that is, the fancy term is epistemic injustice, but that has terrible outcomes, right? And I think what we need to do is, I'm not saying that every, just take everything everyone says at face value, right? But at least have a little bit of humility in listening to what folks are saying about what will get them to success. And I think, the best harm reductionists and the best clinicians have that humility. But probation and parole is not set up for that type of humility, right? It's not set up for like a relation which, the fancy word for that is the therapeutic alliance. But part of a therapeutic alliance is a little bit of humility on the part of the therapist and rejecting what the person is telling you plain as day, is stigma. So sort of, I just had to, towards the end of this talk, get a little bit of epistemology in there as a philosopher. Sorry.
Well, we have just a couple minutes left, and I have been asked to see if there is a takeaway or a key action that you all would like to put on the record. And since I have been totally drafting off you all this whole time and letting you lead the way and I just chime in, I'll start it off. And as a researcher, I'm going to put out this broader systems issue of, it's easy to say, what we need to do? We need to deal with stigma. We need to decrease stigma in the carceral system and treat people with addictions the way we treat people with other serious chronic health issues that need care. And rather than treating them like criminals, we treat them like people who need care. So, but how do we do that? And I mean, that is still something that, like, I threw out the horse before the cart. Like, do we say this needs to happen and then study the process by which the system changes and look at stigma as one of those factors associated with it? Or do we need to come at it at multiple levels and assume that you can't effectively implement proper treatment for people with addictions in carceral settings if you don't address stigma head on? And if so, how do you do that? And so there's I'm looking at a small pilot study that we're doing right now, looking at just person-centered internalized stigma and these intersecting identities that I talked about before. But we talked about how much trauma is part of it. We talked about people who are involved in the carceral system coming from other stigmatized communities in many ways. And the idea that these are really, really complex health and mental health issues. And any light that we can create in terms of effectively helping people at this point, instead of making their lives worse, is a movement in the right direction. But there's just so much more to do. And there's some really important implementation related questions that I know myself and my colleagues are currently working on. And I'll just stop there and throw it out to whoever would like.
Any positive change.
I wanted to give Morgan the last word, so if you don't mind.
Yeah,
I think it's only fitting as somebody who's paid the highest toll of all of us for stigma. I think a takeaway for me is a very I'm a public administrator at heart, although I'm like totally loving my transition to research, but it keeps me practical minded. And I think that one of the things that practitioners need to understand is stigma not only mistreats the person, which it does, and not only violates rights in many cases and fails to meet needs, which it does, but within the larger context in which addiction is set, which is about public safety, which is about stronger, resilient communities, which is about lowering crime, lowering morbidity, lowering mortality. Stigma not only hurts the person, but gives you worse outcomes in all the other ways too. So not only reduce stigma to give the person their due, but reduce stigma to better accomplish all the other goals that you're tasked with accomplishing in public administration, whether it's crime reduction, mortality reduction, keeping families together, reducing homelessness, right? That's motivation as well. Don't lose sight of that too, is the takeaway.
Yeah, I love, oh, I'm sorry.
Morgan, I think we've just got 1 minute, then we can wrap up and go for it. We'd love to have your final thoughts.
That's right. Just realizing that we all have the exact same goals. We all want a healthier, safer society. And while we may have different worldviews, we have shared values. And then really holding those values up and making any positive change. Sometimes people talk negatively about reform because it doesn't go far enough. It doesn't go far enough. I feel like that's people who've maybe not been forced to detox in jail, because any positive change, like giving people medication while in jail, is a huge improvement of quality of life and health outcomes and public safety. And so I just really want people to embrace that. We use it for harm reduction, and it also applies to our carceral systems.
Thank you, all three of you, so much for your exceptional insight and your knowledge and your thoughtful commentary. We're so appreciative of your time and your presence here. For our audience, this does conclude this breakout session, and we're going to take a 10-minute break before talking through some of our innovation sessions, which will kick off at 3:20 Eastern in the main tab. As a quick reminder, instructions for claiming CE will be provided at the end. And it's truly been a pleasure. And the feedback from the audience, you guys, has been fantastic. Morgan, thank you for sharing your story. Brandy and Shannon, thank you for sharing your expertise. It's been fantastic. We really, really, truly appreciate your time.
My pleasure.
All 10 minutes.
Thank you for moderating, Shannon. That was wonderful.